This podcast represents the opinions of our hosts and their guests only. The content here should not be taken as medical advice and is for informational purposes only. And because each person is so unique, please consult your healthcare professional for any medical questions. Welcome to Once Shattered, Picking Up the Pieces, a podcast devoted to changing the way eating disorders and mental illness are viewed in our society. With your hosts, Jack and Linda Major and Ellen Bennett. Today's guest is Rachel Presskreischer. Rachel Presskreischer is a postdoctoral research fellow in the Psychiatric Epidemiology training program in the Department of Epidemiology at Columbia University's Mailman School of Public Health. She is a mental health policy and services researcher with primary interests in leveraging health and social policies to improve outcomes for people with mental illness, health insurance coverage and design, and access to treatment for people with eating disorders. Rachel completed her PhD in health and public policy at the Johns Hopkins Bloomberg School of Public Health, MSSW in social policy from Columbia University, and BA in individualized study from New York University. Rachel is a member of the Academy for Eating Disorders, AED, serving on the Research Practice Committee from 2018 to this year, and as co-chair from 2021 to 2024.
Welcome, listeners. Today, we are going to take a deep dive into research and public policy and learn why it is so incredibly important and essential to move treatment, practice, and more research forward. But first, I need to welcome my soulmate and best friend, Jack Major, and our dear friend and fellow advocate, Ellen Bennett.
Well, it's great to be here again, Linda, and welcome, listeners. And remember, the links for Rachel and your host are in the show notes.
And this podcast is brought to you by two nonprofits that couldn't be nearer and dearer to our hearts, KMB for Answers and the Emily Connection.
Welcome, listeners. We're so excited to be back. I get to read the quote today. Woohoo! We are going to have a quote from Brene Brown. The power of statistics and the clean lines of quantitative research appealed to me, but I fell in love with the richness and depth of qualitative research. Brene Brown, I thought this was so appropriate for today.
Perfect.
Yeah, perfect. Yes. And she has so many great quotes, Brene does. You know? Yeah.
Yes. Yes. She's a name we frequently hear.
Yes.
So it is my pleasure to introduce our guest today. I met Rachel about 9 years ago when we were both lobbying for eating disorders in Albany, New York, which is essential to move legislation forward. Then in 2022, we reconnected through our committee work with the Academy for Eating Disorders. It is truly fascinating how paths cross in the eating disorder world. It's amazing. We have all been honored to connect with so many amazing people along this journey. And now I am so aware that research is essential to impact change about everything, and especially issues related to health, mental health, and eating disorders. Research dollars make the difference between what gets funded and what does not. Rachel, research is so critical to help us understand, process information, and develop new practices. I cannot wait to learn more about your work and how research impacts all of us. Welcome to the conversation with two moms and a dad.
Welcome, Rachel.
Welcome, Rachel. It's great to have you here today.
Well, hello, everyone. It's great to be here. And, I get to talk about a topic near and dear to my heart, which is research, of course, but in the mental health space and eating disorders research, which in my world of sort of health services and policy research is a very, very, very small field. There's not very many of us in public health that kind of study this. The research on the whole in eating disorders tends to live You've got prevention researchers, you've got people who do sort of sociocultural impact on how eating behaviors form. And so you have kind of that world. But you also have all of the clinical researchers who live in psychiatry, psychology, you've got neuroscientists. And then, of course, you've got basic science researchers, people looking at genetics, people who look at biology at the sort of molecular and cellular level. You've got bioinformaticists who look at the large data that we produce. And you have people kind of in my world of public health who look at not really the intervention strategy at the individual level, but sort of public and population level interventions, population level impact. And that can be sort of at home, globally. You've got services researchers and people like me who look at how much does this cost, what kind of services should healthcare provide. So it really kind of runs the gamut in the research world of lots of different fields and professions getting in on this work. And I think a lot of that isn't always so visible to kind of the general public of how many people that may span, even though we're a very small proportion of research in general.
Wow, you just taught me a lot of
Wow,
I didn't realize, yeah.
It makes me feel like a flea.
Every time I talk to you, Rachel, I am just amazed. It is fascinating.
So, Rachel, can you tell us about your decision to pursue research and a career in the field of health policy, and what life experiences or personal connections inspired your educational goals and your professional goals?
Sure. So I think there's kind of the people who seem to know what they want to do off the bat and they go that route. I have a very good friend who's a pediatric cardiologist who told us she was going to be a doctor when we were in like 6th grade. And then, you have me who took a little bit of a circuitous route. When I was in high school, I lost a friend to suicide when I was about 17. And I also had a good friend when I was in high school who had a pretty severe bout with anorexia, who now is, recovered, married, has kids, kind of got good treatment. But, I was sort of keyed in young to the severe version of mental health impact. And I think I kind of grew up with, it was still much more taboo to talk about. If you had a therapist, you didn't really tell anyone. Yeah. But by the time I had sort of gotten to college, it was becoming more common for people to talk. And now I think it's much more of a conversation. But I thought, both my parents are psychologists. I thought, I'm going to do something in the psych world. And then realized I absolutely did not want to do that. And so I then got sort of connected to the world of what's called sort of macro social work, social work that sort of happens more on the systems level, services. I was much more interested in kind of connecting people to care rather than being the care. And through that, I took a course in policy and fell in love. And then I kind of got wholly hooked into, let's go even further upstream. I don't know if you've ever heard the analogy of, there's people who are sort of falling into a river and you're sitting on the banks and you see all these people floating by and you've got the people that jump in to rescue them. And these people keep coming and coming. And somebody says, we should figure out why all these people are getting pushed into the river. Mm. And, sort of the clinical and the micro people in social work and in clinical work tend to be the ones pulling people out of that river. And the macro people are the ones who kind of go upstream and say, where is this problem coming from? Why is this happening? And you really kind of need both. You need both those things.
That's a great analogy.
Really
oh my God.
I've never heard that before.
Yeah. Is it okay if we steal that going forward?
Yeah. Yes, absolutely. It's certainly not my analogy. But you need kind of all those pieces. And so I really, sort of first thought I'll be in the middle, kind of at that services level, and then fell in love with the sort of big picture of really looking at policy and huge systems. And I ended up working. So the National Eating Disorders Association at the time was one of the only, I was in New York as a social work student. They had one of the only sort of mental health advocacy type policy work, internship openings that I could do as a student. And so I ended up there and really kind of said, okay, like I like this. And I ended up getting hired on after and kept coming up against the problem that information just wasn't there. Like, oh, let's, work on a program around health insurance or healthcare or whatever. And we didn't know anything. It was like, we don't know how many people are affected in this way. We don't know what kind of treatment people get. We don't know. And so I kind of reached the point like, well, I'd like to go find out the answers. I was very interested in the answer to the question as opposed to making sure people, who called the helpline got a service. I said, well, let's figure out what everyone needs. And so I said, I'm going to go back to study, policy and services and government. And I ended up getting a PhD. So, it's not what I set out to do, not what I thought I would sort of do in a straight way, but that's where I ended up.
Now I know why you're so incredibly special. That's awesome.
Yeah.
When you think about that, you jumped in and said, we need answers.
Yeah.
Thank you.
Yeah, you closed that gap. I mean, yeah, that hole.
But,
we'll close the gap when we get the answer.
But I
haven't done that yet.
There has to be a passion to do what you do. I mean, there's always barriers, there's always setbacks, but when you're passionate about something, you just find a way to keep moving forward.
Yeah.
And you will be, and you have, I'm sure, already been instrumental in a lot of the differences and the changes that have happened. So I think that's great. So what can you explain the term psychiatric epidemiology to our listeners and us too?
Sure. So, epidemiology as a field, I think, became much more visible during COVID things, and people got a little more aware that the epi people are the ones looking at, how do diseases spread over populations, and how do we stop transmission of communicable disease? So that's the more kind of, I think, commonly viewed image of epi. But there's all kinds of epidemiology, including psychiatric, but there's cardiovascular, cancer epi. And on the whole, it's really kind of looking at population level distribution of disease, of illness, thinking about population level intervention or solutions. And so I, from a services standpoint, thought, well, in order to do a good job with policy, with distribution of resources, we need to really understand how are we counting people. At a very fundamental level in mental health, one of the challenges is, you can't do a blood test and say, oh, this person has this, or a throat swab and say, oh, it's positive for strep. We don't know real quickly what is depression, what is not, what is an eating disorder, what is disordered eating, where's the line between a quote case and a subclinical case. And that doesn't necessarily matter in the treatment side. Anyone who has distress should be able to access treatment. But when you think population resources or distribution, you have to sort of think, where are resources most needed, or how do we best direct our, finite resources to the right areas, and who's not being reached and who is. And a fundamental part of that for me was, we got to figure out how to count. And so I have spent, and you'd think, oh, that seems like it shouldn't be that hard. But in reality, it's very hard. It's hard because funding research to just do counting is very hard. It's labor intensive. Just thinking about who do we send out to figure out if it's a case or not? Is it diagnostic, or is it sort of self-report? What are we going to do? So all of that piece was of interest to me, not because I want to necessarily commit myself to doing that work, but because I feel that in order to do a good job with thinking about resource research or research on healthcare, you got to understand who's being counted and who isn't, and how are we counting and doing that accurately. And so I've had the privilege of being at Columbia in one of this program I'm in has been consecutively funded for over 50 years, I think, and is sort of a foundational hub of psych epi research. And so I've gotten to work with some great people on just the methodological approaches, how they think about questions, and has helped me kind of build a stronger foundation to hopefully go forward and do research that has really, really applied applications, which is, a bit different than the people doing the real biological basis research. That takes time to get into intervention design. And I'm sort of saying, all right, well, we have some things that work. We just don't get them to all the people. How do we improve that? So it's, it's a little downstream in that way. Yeah.
So is the funding state funded or federal?
So this program is funded through the National Institute of Mental Health. It's the NIMH has things that are called training grants. And those are programs that are set up, an institution applies to train people in a particular field. And that can be training, these type that I'm talking about are training researchers. So that can be pre-doctoral, they're in a doctoral program, whether that's a PhD or MD, or it's postdoc, where it's completion of an MD or PhD, and then you get additional training in a particular topic. Okay. So Columbia also has a training program in eating disorders for postdocs in the Department of Psychiatry, for example. So, there's many different forms that these can take, and the one I'm in is Psych Epi. But at Johns Hopkins, I was funded through a training program in mental health systems and services. So a little different.
Okay. All right. Well, it's become painfully apparent how important research is, especially for public health. And there's no funding, there's no research. And funding drives the change. Research drives change. Will you give us a brief overview of the research process and some of its complexities, policy systems, and frustrations that you have along the way?
Sure. So, that is definitely one of the most opaque processes, I think, to people outside of academic or medical research settings is like, why are some things funded and not others, or how does that get decided? And it differs depending on what country we're talking about. So I'll primarily talk about the US, but, depending on where you are in the world, how funding happens and what gets funded differs. Here, there's sort of two mechanisms that people get funding through, and that's government research grants or foundation research grants. There are, of course, private companies that also fund research. I think people have a very negative connotation with private companies funding research. It's not always the case. There are, for example, companies that might be developing technologies or medications, but they need to find out, the same information we need as clinical research, like how many people are affected. So they may hire academic researchers to do basic research as well. That's less common in my field, but more in some other fields. And then through government research, that can happen at state level, federal level. The big federal agencies for health research tend to be the National Science Foundation and the National Institutes of Health. The NIH is huge. It encompasses many different sub-agencies, and each of them have slightly different processes and whole kind of priority lists for what they fund and how they fund them. And then for foundations, those can be like a massive foundation that chooses to have a health portfolio, or it can be like a very specific targeted foundation that may have a health as their whole focus. And so the difference there kind of depends on what you study and sort of how much of a priority that is for whatever agency or foundation you're applying to. On the private side, you can they have an open call. You can sort of submit a proposal briefly, and then they may invite you to submit a full proposal. Some foundations don't accept proposals at all, and they reach out to researchers, or you build a relationship with them. And then you're able to kind of contact the people and see about getting your projects funded. the variability in terms of foundation funding and, what they ask of you as a researcher is high and how much money they give you. But the NIH and the National Science Foundation tend to have more outlined processes, and similarly in state government, they're more accountable to the public, right? So you as a public taxpayer, theoretically, should be aware of how the government's spending your money. And so in order to do that, there's very intricate processes. Typically you end up submitting like over 100-page document of what you're going to do for your project, every single person that you're going to be funding on the project, all the expertise that'll be included, what the outcomes you're expecting to be able, like what deliverables you'll have. And then that gets reviewed by panels of peer reviewers who score them. And then so there's deadlines that are set up. It's a long process, but there's very large grants to be gotten at times through federal government. There's other mechanisms like the Department of Defense, for example, funds health research. Sometimes that's, people through what people assume to be sort of more nefarious things like, we want to fund bioweapons, but they also care about things like illness among service members or service member families. Yeah. So there's lots of kind of different ways people get money for their research, but you're kind of if you're on what's called soft money, which is grant funded, you're constantly sort of applying for and trying to deliver on grants so that you can keep yourself and your people employed.
Mm-hmm. Yeah, of course. Yeah.
So it's a kind of constant process. Some people really hate it, and so they really don't want to be part of that, or they find it exhausting. That passion or that level of enthusiasm, I think some of us are a little bit excited by the opportunity to write new grants, to put our ideas together, to sit down with our colleagues and build out an idea and really turn it into something that we think we can study. And so, it's a double-edged sword because you have to constantly convince someone else that your work is worth funding. But at the same time, you get to kind of put your ideas forward, and it's new knowledge generation to a certain extent. And that's, for us really big nerds, that's the exciting part.
Yeah. Yeah. Well, I think all three of us have been involved in, going to Albany and looking for the funding for the comprehensive care centers that are in New York State. The three
Yes.
that are here that, we have to go and.
Well, that's where we met you the first time.
Yeah, that's where we met you the first time. I think
Yes.
it was in 2017. I think it was. Yeah. So, and it's it's eye opening when you go there and you're asking for, $1 million, whatever it is, out of a multi-billion-dollar budget, and they all agree that the money is very well spent and much needed, but it's sometimes feel like begging, and it's hard, especially for eating disorders, because as the amount of money spent for research on eating disorders is I think less than $1 per person. I don't know what the current amount is, but versus some of the more mental illnesses, and everything's important. I understand that, but when you're looking at something that's
the deadliest
deadliest mental
psychiatric illness outside of opioid addiction.
Yeah.
So,
It's frustrating. So, but thank you for all the efforts you do, and I know it's exhausting and it's frustrating sometimes, but thank you for continuing it and being excited about it.
I wanted to continue this conversation about research and mental health and eating disorders, because I'm kind of feeling like there should be some opportunities that have opened up within the last 4 to 5 years for expanded research. And I'm just thinking, even within the eating disorder field, there are some private foundations who are offering research opportunities. NIDA now has a fund for research. And I'm thinking Project HEAL as well. So what are your thoughts on that in terms of right now and looking ahead for good research opportunities?
Yeah. So, as depends a little on the kind of research that you do. And so, one of the things that's always a challenge is that clinical research, at least, where you have patient populations or, kind of the quote, typical human subjects version of research can be pretty expensive, depending on what you're doing. Intervention design, are you paying a clinician to deliver an intervention? Or, how are you compensating your participants for their time? What type, do people need to travel? Do people, are you doing MRIs? Are you, so the resource, the amount of money you have to spend can build up very quickly. So one of the things that can be very nice about, smaller foundations or these kind of awards through NIDA or through Project Heal or whoever offers them is they can fund pilot data. So, sometimes you have an idea and you put something together, but to convince the federal government to give you $500,000 over 3 years or whatever timeline, you need some evidence that your intervention might work, or something that indicates, we can test this. This is testable, or, in my case, it might be, I've been able to look at some data and show that, the population I'm interested in studying exists. And so those kinds of smaller grants are great to kind of get pilots or startup kind of initial aspects of things. And I think one thing that, for me personally is a challenge is most of the foundation work appropriately wants to fund treatment research or intervention research or prevention. And what I do is neither of those things. It's much more in the population level or the sort of services or policy level. And so it's tricky to convince, a human service-oriented organization that you want to study health insurance costs. Even if they know that's useful, it's easier to go to your fund, your fundraising projects and say, yeah, we want to fund treatment research. It's a little harder to convince your donors that funding a study on health insurance is like the most worthy cause. And that's, for the kind of horizons moving forward, though, the NIH doesn't typically have specific illness studies for eating disorders. Not usually, but the National Institute for Mental Health has certainly funded eating disorder research before. There are also studies that sometimes will look at things like co-occurring illnesses. So it could be that you're looking at, eating disorders and non-suicidal self-injury or suicide epidemiology or something like that. But I believe it was 2021 or 2, they put out a specific call for a small type of grant to look specifically at relapse prevention programs for anorexia nervosa. So it was specifically for that. And if you're, as a general public member, interested in what the National Institutes of Health are funding, you can actually look it up. The NIH has a website called Reporter, spelled just like you would for a journalist. And you can type in, as a search, anorexia or eating disorders, and you can see every study that's been funded, it'll have a little bit of a little synopsis of the study, but it will tell you who it was that applied for it, what researchers, what institute they're at, how much money it's for, how many years it's been going on. And then if there's any papers that have been published connected to it, you can see papers are. And most research that's funded by the NIH eventually has to be publicly available. So, it may be on a delay, like it may be a year or two later, but you should be able to read, obviously it's research, so it's a little bit different than narrative writing, but you can see if they've published studies out of the work they've done. And so there are, I believe, I actually looked for that particular call. There's, I think, 4 current or, kind of ongoing studies that are being conducted. One at the University of Louisville, one at the University of Kansas, one at WashU in St. Louis, and one at VCU, and there's a 5th at Columbia. Mm-hmm. So there are 5 sort of ongoing studies looking at relapse prevention after acute treatment for anorexia. So, it's not all bad news.
So can you tell us what PsychPac is and how that'll impact change and access to different treatments?
Sure. So before I talk about PsychPac, I think it's probably helpful to kind of back up a little bit. And so for mental health services in terms of therapy and different things, you have many different professions that can deliver treatment. So that, includes psychologists and psychiatrists, as well as master's level clinicians that are marriage and family therapists, counselors, social workers. And then you even have advanced practice nurses who can do things like prescribe psychiatric medications if they complete their studies in psych nursing. And so as a result, those professions are all licensed at the state level, and they're all licensed individually by different boards. So, the medical board oversees medicine, the nursing board oversees nursing, social work. So there's lots of different rules and regulations for what kinds of training you need and what type of things you need to do for continuing ed to maintain your licensure. And as a result of that, if you want to be licensed to practice in multiple states, you have to be licensed in all of those states. During the pandemic, one of the things that sort of came of that was of course, this huge push to telehealth. And that was an initial kind of de facto opening up of access for people who may have been in more rural areas. If you're in rural parts of New York State, where we all are, it can be harder to find providers than if you're in major cities, Rochester, Albany, New York City. And similarly, there became some special emergency authorizations for clinicians to be able to get licensed or practice across state lines. And that was, I was a graduate student at the time, and that was majorly beneficial to undergrads, many of whom went home to their families after having to move out of dorms. And so they were able to keep seeing the clinicians that they may have been seeing while they were students when they went home. And that kind of, I think, opened a bigger interest in how do we figure out cross-state licensure and psychology. So that's, I believe PsyPac specifically is applicable to doctoral, so PhD or PsyD level psychologists specifically, is what's called a multi-state or interstate compact. So a number of states have, many at this point, I think, signed on to this. And what it does is allow psychologists who are licensed in any one of the PsyPac participating states to practice in other states. So if you are someone living in, I don't remember all the states off the top of my head, but like say you're living in Indiana and they participate and you move to Illinois and you don't want to change therapists, if then both states participate, your therapist can keep seeing you across state lines.
That's wonderful.
And
that's huge.
It's a continuity of care, potential. And also, so New York State, for example, I believe has it currently in the legislature, to join PsyPac. I'm not 100% up on how popular or not that is, but I'm not sure what the arguments against are. And virtual care is a great resource for many, many, many people. Yeah. And for some conditions, it may not be appropriate. For some people, it may not be. For example, someone with an eating disorder, if they only have a virtual provider that they've never seen in person and they don't have any other medical management or any person who sees them ever in person, I don't know that many clinicians would be super comfortable with that. But it may be appropriate for some people who don't have, medical complications, or if that's not necessarily of concern as much, then they may be able to maintain a specialist provider who's far away.
And if you've already have a relationship with a therapist and you move, it's really hard for people sometimes to start all over again. So I think that's positive. And like you said, telehealth works for a lot of people and for a lot of different situations. So we can't put everybody in the same box. So
yes. So it just gives more options,
Yes.
essentially. So the SciPac
Absolutely.
move, may open up opportunities in other fields, whether the other professions will get on board with that. And then there's also, some stuff around medications. If any of the listeners know anyone who has ADHD, for example, controlled substance medications can't be e-prescribed across state lines usually. So if you have a psychiatric provider, whether that's a psych nurse or an MD in one state, and your kid goes, let's say, to college in another state, it can be very hard for them if their university doesn't have resources to get that medication while they're in the other state. But that's a very specific situation.
Well, that's good. That's good that they're changing and being open to that option for people to be able to get continue with their therapist. So you're starting a new position in July. We're recording this in June, and it's going to come out after you have this new position. So can you tell us about that new job and what you'll be doing and where you'll be working and how this will support your career goals?
Sure. So I'm going to be a research faculty member at the University of North Carolina, Chapel Hill, in the psychiatry department. They received a pretty substantial private gift to start a suicide prevention institute. And it's got a pretty multidisciplinary group. They are also working closely with the state of North Carolina on some interventions. And it is spread across some different projects. So there are elements of, I believe, a school-based kind of prevention intervention that they're working with the School of Education on as well. So like they just, the head of it and Dr. Cindy Bulick's also affiliated, but she's in the Center of Excellence of Eating Disorders. But she and the head of this is Patrick Sullivan, are both jointly appointed at the Karolinska Institute in Sweden. So we're able to use some of the data from Sweden as well. They just completed, I believe, like a suicide epidemiology study using Swedish register data, looking at the incidence of suicide in Sweden. And we're hopefully going to be taking data from health insurance claims as well as the electronic health records in North Carolina to look at suicide outcomes among youth across the state. But I'll also have some opportunities to do some work with the eating disorders group using some different types of data that they've collected. And what's exciting for me is, this is a kind of, could look like an off-ramp from my policy work into a little bit more kind of applied and clinical work. But to me, it's kind of part and parcel of one big, how do we get resources and information to people who need it? How do we better understand what's happening in our population so we can respond effectively? And so I'm really excited to kind of take that on and hopefully write a grant to fund some work. I'm interested in a lot of things related to kind of how health insurance is structured in terms of how it does or doesn't really facilitate access to the right types of specialists in mental health services. And sort of how it affects people's longer term outcomes.
And as you look forward for the next 5 years, what do you see yourself doing and what are your long-term goals, past 5 years?
So I've kind of, I think, learned to take it as it comes, kind of, as opportunities arise, as I connect with different people. And, one thing that is a pro and a con of my approach to research is I can get interested in all kinds of things. I have a very, very good friend from my doctoral program whose primary research area is injection and infusion drugs in the Medicare program, who studies Medicare Advantage, who studies prior authorization policies in that program. And I've worked with her before because I love working with my friends, and so I have loved the opportunity I'm getting at North Carolina to really engage with people in the clinical research space. And so I'm hoping to potentially work on, how do we translate what we know from clinical knowledge really into practice? How do we help, clinicians who are outpatient solo practitioners get information that's coming out of research? I think sometimes it's easy to forget that when you're in private practice, you don't have access to academic journals. You don't necessarily have access to free training on new treatment interventions. And so every day that clinicians in private practice don't work, they don't get paid. And if you want them to be working, you want them to get trained, they got to pay for it.
Right.
And how do we help better get those things translated?
Got to go back to health insurance. It's so prevalent in all of our lives, and coverage varies from state to state. Help us understand how and why health insurance varies so widely depending on where you live. And type of insurance, socioeconomic factors. Give us your, thoughts on that.
I will do my best to give the least nerd wonk answer to that. So if we sort of take a historical perspective for a moment, nobody who was designing a healthcare system from scratch would design the system we have in the United States. So sometimes when I hear people say, it's so ridiculous, this system, we should just do something else. And I'm thinking, well, no one sat down and said, yes, I think we should have a really convoluted, complicated system with multifaceted elements that no one can understand. No one did that. It was sort of created very piecemeal and in response, it's a responsive system to things that arose at a given time. So if you're real interested, you can go find out that doctors are actually the reason we have health insurance in the first place. They invented it. But the kind of initial idea was, a really expensive event, similar if you think about like car insurance, like an accident, we don't want that to bankrupt people. So let's come up with systems and ways to sort of pay for services. And that's the kind of catastrophic model. But as we evolved, we had to think about different ways to pay for people's healthcare. And, you get World War II, we had a big freeze on people's wages and not allowing people to sort of expend great amounts. And so we shifted to offering benefits like health insurance through employers. It's sort of a lot of why our system is the way it is a product of the time that each piece was made. And so, we came up with a system. We said, oh, wow, older adults are really struggling they end up in poverty because of healthcare needs. So we invent Medicare to kind of help people who are older. Then we say, wow, people who are really low income or poor, they're, people with kids or children themselves are really struggling. We think, for whatever reason, that we should have a cutoff of if you make this much money or less, we should cover you. And that program, the Medicaid program, which is called many things in many different states, has flexibility built in to be a state program. The Medicare program is a federal program. And so we have many systems and many piecemeal things happening. But the sort of idea is that we hope to cover everyone in some way. And, the Affordable Care Act in 2008, and then sort of expansions of Medicaid, depending on what state you live in, have gotten more and more people covered. And then what the benefit design looks like varies dramatically depending on even employers. Among private plans, your employer often sets the benefits. And so there's a lot of different rules and regulations because there's a lot of different programs. And so, unfortunately, the sort of easy answer is it's very complicated, and the best thing to do is sort of ask a lot of questions and look at your policy as best you can. But I think the big overarching kind of thing about health insurance is that it doesn't function like other insurance in the stereotypical sense. Your car insurance doesn't cover routine maintenance on your car. Homeowners insurance doesn't pay to get your gutters replaced. And so our healthcare has become a proxy essentially for purchasing quote unquote healthcare. It operates a bit differently, and that makes it tricky. And, whether we're going to change that system or not, I don't know. But hopefully we come up with a good way to get people care. And in mental health, it's just hard because some people are, you have people who are very high need and some people who have less needs, and what those needs are, whether those are just health or sort of psychosocial needs as well, like housing or employment support, also create challenges around, are those healthcare needs? Are they not healthcare needs? And sort of how do you best support people who have chronic illness in general, whether that's psychiatric or not, is a sort of secondary question. I don't even know if I answered your question, Ellen, honestly.
No, I think you did. I think it's frustrating because the whole healthcare system, especially when in regard to mental health, there's just not enough educated medical professionals to help all the people who need and deserve help, especially with psychiatric illnesses, but a lot of illnesses now. And I think COVID just exacerbated so many things that were already a little wonky, and now they're really wonky. So,
well, it just brought out, everything in the press and some celebrities and stuff that came out, and that's wonderful. But, mental health issues and the lack of help for those people has been there for a long, long time. And, the thing, as a retired pharmacist, that I saw, one of the first big changes was when President Bush signed Medicare D, gave a drug plan to the seniors, right? But he didn't know what to do, so he said to the insurance industry, you guys come up with the parameters and you run it, and they all did it, for their own end result, right? So there was some good plans out there and some not so good plans. And then Obamacare came along, and same thing, the insurance industry ran it, and there was some very low plans out there for a year or two, and those all went away. And now it's just, just like healthcare systems are just gigantic,
You mean low cost?
Yeah, low cost, yeah, and low care too. But so we have just huge conglomerates out there that control everything now, and it's for their benefit more than the public benefit, from what I see. And from in talking to people, everybody you talk to, you go to dinner with somebody, or you have somebody for dinner, or you just a general conversation, everybody hates their health insurance, But what you said earlier about, you have car insurance so that if you total your car, okay, that's covered. You have homeowners, so if you have a fire in your house, that's covered. So we have health insurance so that if we have some catastrophic, heart attack or some, long-term hospital, say it's covered.
We're grateful for health insurance. It just needs to do more with the dollars that we put into it. And also, medical care is so prohibitively expensive now. I mean, it's just off the charts. Well, yes, but healthcare for sure. I mean, yeah.
Prescription.
Especially when it comes to mental health and residential treatments and things like that. It's so expensive.
Yeah.
Anyway, I know you hear this all the time.
I'll say, if it's sure, but if it's of any comfort, we're not doing measurably worse than other countries in access to mental health services. It's bad here, but there are upsides and downsides to every system that is set up globally. And so when you think about, I think some people commonly will think about the United Kingdom having sort of a quote unquote socialized medicine or a government system, or Canada that's got a sort of government payer. And there are upsides to that, in terms of cost to citizens, and, that's great. There are also, in the UK, they have to necessarily make decisions about what treatment is available to who. They have to spend a whole pot of money across the whole population. So how much do we spend on any given person for any given condition? They have to do all these kinds of calculations in a way that, in the US, if someone tries to tell you we don't ration care, they're lying to you. We do. We just don't do it at the government level where somebody says, you get this much treatment and you get this much. We do it based on if you can pay for it. And so in some ways, here you can access a lot more stuff than you can in other countries. We have wait lists, but we don't have the same type of length of wait list or the restrictions on who can get care. So if you can afford it in the United States, you can access treatment at an early point. In the UK, that's not necessarily true. You have to meet criteria to meet with the mental health team, or you have, the way they have it there is set up by region in a certain way. And so, does your region have that provider or not? Can you get sent to another region? They do have private services there. It's different. But, here, if you can't afford it, you're not getting it, which is its own kind of rationing. But if you can afford it, the wait lists don't exist in the same way. And so there's, downsides and upsides to every system. But we're doing just as badly as many other places for different reasons.
Well, and sometimes it's very hard to compare a very large country to a very small country and how they do things. So yes. I understand that too. So
yes. But, it's not all doom and gloom in some ways. There are attempts at coming up with better ways to pay for care, better ways to think about how we spend money. But, that's my friends do a lot of that research in the sort of health economics space. And that doesn't always trickle down, but there's a lot of questions about privatization of healthcare and things like that. So hopefully we'll solve that one day.
Okay. Give us a ray of hope for mental health. Moving forward.
I think, on the up, as much as advocacy and legislative things are slow, research is not an expedient process. There have been changes. There have been dollars allocated to different types of work, and advocacy makes a difference, and it shows up in legislative efforts and at state levels or local levels. And I can thoroughly appreciate the frustration that a lot of people face, but from a research perspective, at least, there's steps being made and people working on trying new things. There's work and how do we get technological advancements into clinical care? How do we leverage bigger data to better understand courses of illness? And so hopefully that will, trickle down. It'll take time, but it's not at nothing. We're not still fighting the exact same battle we were fighting 10 years ago.
And we have incredible researchers like you saying, we need to know, we need to understand. I love it. Sure. Okay. On a personal level, tell us how you recharge and decompress, and how do you balance your work life?
So I'm actually more of an introvert. I love talking about research and science, but I love to hang out with I have a 12-year-old corgi, and I love to just take her for a walk in Central Park, where I'm moving, has walking trails nearby, and just sort of wander around in the woods, thinking about research, thinking about other things, but taking the time to kind of get outside. And I like to read, I like to play board games, hanging out with people who do completely other things that are just completely not related to my work is a nice way to remember that there are other things out there besides research and the computer and the data that I sit with most of the time.
This has been a great conversation. I thank you so much. I think you're very inspiring, and I've learned so much from you. Keep doing what you're doing, and best of luck in your new adventure.
And I would never know you were an introvert. You talking to you this last almost hour.
You're getting me to talk about this stuff I'm interested in.
So what I call myself is an extroverted introvert. Maybe that's what you are too.
I would say I'm an outgoing introvert. I'm not shy, but boy, will I need if I go to a conference, I spend half the time in the room by myself.
Well, thank you for everything that you're doing and sharing your knowledge with us. Is there anything really quickly that you would like to add that we didn't ask that you would like our listeners and us to know?
No, I think we've pretty much covered it. That it's not a hopeless case. And yes, healthcare is very complicated and frustrating. And lots of us are trying to find ways to make it better.
Thank you.
Thank you for that.
Thank you so much. This has been absolutely wonderful. And thank you, listeners. Our daughters and you are the reason we do this podcast. And a warm thank you to RockVox Recording and Production and Scott Fitzgerald, who is RockVox. He's a sound engineer extraordinaire, and he expertly produces our podcasts every time. Thank you, Scott. And he does so much more.
Please rate, review, share, and subscribe to Once Shattered, Picking Up the Pieces on the podcast platform you are listening to us on. Help us continue the conversation. Tell your friends, your family about us, and check out the show notes to learn more about Rachel Presskreischer, research, public policy, funding, mental health, and eating disorders, and learn more about Jack, Linda, and their book, Emily, the Story of a Girl and Her Family, Hijacked by Anorexia, and their nonprofit, The Emily Connection.
And also learn more about our wonderful friend and colleague, Ellen Bennett, and her nonprofit, K&B for Answers. Please remember how important these conversations are, and because everybody's mental health matters. Everybody knows somebody. Everybody's dealing with someone with mental illness. So if you're looking forward to a place to record your podcast, this is the place. Record your audiobook or do a legacy cast for your loved ones. The only place to do that is RockVox Recording and Production. That's our recommendation, and I guarantee you won't be disappointed. Thank you, everybody, for listening.